So, good morning, everyone. I'd like to welcome you on behalf of Rare Disease Society Nepal to this morning session. Today, we have a distinguished guest of pediatric neurology, Dr. Asim Shrestha. Talking about Dr. Shrestha, he is associate assistant professor at Kathmandu University. His area of interest in pediatric neurologies are gait and movement disorders, ASSD, behavioral disorders, then seizure, spinal cord disorders, and many more, like cerebral palsy and many more. So right now, he is working with Upen Devkota Memorial Hospital in Masbari, and today he is going to talk about the rare genetic and metabolic diseases which mimic with the cerebral palsy. Dr. Shrestha, the floor is yours. Now you can
Uh-huh.
start with your presentation. Thank you so much.
Thank you. So, good morning, everybody. Sorry for the technical glitch again. My camera is not working. So, my topic of without further ado, let's start with the presentation. So, my topic today is CP mimics. Right? CP भनेको everyone knows it's cerebral palsy. So, mimickers of cerebral palsy. So, I'm Dr. Asim Shrestha. So, Dr. Rupesh has introduced me previously as well. So, I'll like to go ahead with the presentation now. So cerebral palsy. So everyone is familiar with this term, cerebral palsy. So it's one of the commonest OPD visit, which is the patient comes to us in child neurology. So briefly, we'll go through the introduction of cerebral palsy. So what are the risk factors? So what are the typical MRI features that are seen in cerebral palsy? Then we'll say what is not cerebral palsy. So what mimics cerebral palsy? So cerebral palsy, these are the group of permanent disorders of the development of movement and posture that is attributed to a developing brain mass when there is a non-progressive insult that has happened, usually during the perinatal period. So again, I'd like to highlight that this is a non-progressive insult that has occurred in a developing brain. So the symptoms usually are non-progressive. However, the symptoms may evolve over a period of time. The symptoms usually they evolve. The motor features that are present in cerebral palsy, they include hypotonia, spasticity, weakness, and involuntary movements like the dystonias, the chorias that may occur either alone or in combination. Usually they occur in combination. So spasticity goes in hand with dystonia, and the other way around, the dystonia goes hand in hand with spasticity. So the three predominant motor symptoms that happen in cerebral palsy are spasticity, dystonia, and ataxia. So we'll discuss about that in successive successive PowerPoints as well. And the motor symptoms, they are frequently accompanied by a variety of non-motor neurological features like as well, like the IQ may be low, there may be behavioral symptoms like hyperactivity, restlessness, there may be sleeplessness as well, and seizures if there is a cortical involvement. So yeah, so the typical neurological sequelae that occur in infantile brain injury that may occur because of prematurity, like in our part of the developing world, mainly the intraventricular hemorrhage, the periventricular hemorrhage, the neonatal hypoxic ischemic insult injury, the central nervous system infection, or the trauma. And the typical MRI patterns. So the tendency that we have is whenever there is a brain injury, then we go for CT scan. But the CT scans may miss the typical MRI features that are seen in cases of cerebral palsy. So the predominant MRI picture that is seen in patients with cerebral palsy, they are seen in the white matter. The white matter injury is the commonest, and the periventricular leukomalacia being the commonest one, seen in 19 to 45% of the patients, followed by the gray matter injury, 21 to 25% of the patients, and focal vascular insults in 10 to 13% of the patients, and malformation seen in 11 to 17% of the patients. So the characteristic lesions seen in patients with cerebral palsy in MRI brain is the PVL that denotes periventricular leukomalacia, the thalamic and the basal ganglia ischemic lesions, the cerebral hemorrhages or the strokes, and the cerebral dystenosis. So yeah, the thing that I'm trying to depict here is that different kinds of brain injuries seen in patients with hypoxic brain injury that is very common. That is very common in our part of the world. So we can see here that this is the DWI image. So you can see the hyperintensity seen in the rim of the cortex. So these are called watershed infarcts because of hypoxia. If the injury is prolonged, that may involve the deep gray matter as well, involving the gray matter, the thalamus, and the basal ganglia. If it's the global hypoxic injury is very severe, this may spread wide. This may be very widespread, involving the cortex, the white matter as well. That can be visualized very clearly in our MRI. So these kind of images can be missed in the CT scan of the head, and this image depicts the hyperintense lesion, hyperintensity noted in the bilateral hippocampus. So different kind of brain injuries are seen in patients with cerebral palsy, but the predominant one is the periventricular leukomalacia. So typical child with cerebral palsy, how do they present? So they have developmental delay. So you can see the spasticity is there. You have this cross leg posture is there. So on examination, uh, the patient had spasticity. The patient had upper motor neuron type of features. The tendons were the bisc tendon reflexes were there. The plantars were upgoing. So we did the MRI of the brain. So MRI of the brain, we can see here, it shows that the cortex, predominantly the frontoparietal area, is not that well developed. They are quite thick as well, and the parieto-occipital area cortex is quite well developed. We can see the ventricles, lateral ventricles are quite elongate. They are quite enlarged as well. You can see the small outpouching arising from the right lateral ventricle as well. So this is congenital brain malformation called as Lissencephaly pachygyria complex. So we do the lateral sagittal section. We can see small cleft-like structure coming from the frontal area and that have connection with the lateral ventricle. And this cleft is surrounded by the gray matter. So this is a schizencephaly. So the schizencephaly has given rise to spastic diplegia kind of a cerebral palsy. Then coming to our main topic of presentation today, cerebral palsy mimics, or what is not cerebral palsy. So this is a condition that is manifest with clinical syndrome that is consistent with cerebral palsy, but in the absence of documented risk factors or the typical neuroimaging findings that we just talked about that I just talked about previously as well. And the cerebral palsy mimics, usually they are of genetic or metabolic origin, and that will have clinical features that fit with the CP phenotype. And these disorders, they are thought to be of developmental, that is symptomatic from birth and that are non-progressive. And while some are neurodegenerative, that have onset at variable intervals postnatally, but the symptoms gradually progress as the child grows older. Why do we need to find the diagnosis of neurometabolic conditions? Because they have specific targeted therapy that may improve the symptoms and their developmental outcome. So what is not cerebral palsy? When there is absence of, when do we suspect it is not cerebral palsy? When there is absence of risk factors of brain injury, like there is no history of pre, peri, or postnatal insults in the brain. Like in the antenatal visits, the pregnancy went very good. The patient did not have diabetes. The patient did not have hypertension. The patient mother did not have any fever, infection, because these kind of insults can give rise to brain injury. Or during the perinatal period, the labor was normal. There is no obstructed labor. Postnatally, the child cried immediately. The Apgar was quite good, but still the child has motor delay. Then we suspect, could it be just a cerebral palsy mimic? And the most common cause of these complications that occur are the prematurity, intrapartum asphyxia, intracranial hemorrhage, infection, stroke, jaundice, or trauma. When these features that give rise to brain injury is not present in the history in the patient, then we suspect, could it be cerebral palsy mimic? Then the clinical course. Usually the clinical course of a cerebral palsy is it's a non-progressive insult, whereas the symptoms severity may vary, but usually what the parents will say is that the child is gradually doing well. But if suddenly there is a neuroregression, a well-developing child, there's neuroregression, or the neuroregression is there, then we suspect, could it be a non-CP? The motor symptoms in CP usually tend to be relatively stable from moment to moment. The marked fluctuation is there, or paroxysmal symptoms are there in relation to when there's in date, activity, or fasting. This is not typical of CP. So this can be seen in case of neurotransmitter disorders or the GLUT1 deficiency disorders. The CP child, they have development delay, but they do not regress developmentally in the childhood, early childhood years. Then the clinical findings are inconsistent. The typical CP finding, patients will have spasticity, brisk tendon reflex, upgoing planters. But when these symptoms are not there, then we should suspect, could it not be a CP? Or when there are eye movement abnormalities, very unlikely that that a child with cerebral palsy will have eye movement abnormalities. There could be oculomotor apraxia in cases of ataxia telangiectasia, or the eye saccades, repeated head that's called eye head gaze saccades in case of typical GLUT1 deficiency syndromes. The ataxic variant of cerebral palsy, like I said before, is very uncommon. So if there is isolated ataxia in a child you suspect of cerebral palsy, we should think, could it not be CP? Especially if the child does not have spasticity or dystonia, or the child has myoclonus or myoclonic epilepsy, or the child has some facial dysmorphism. Could it be some genetic condition giving rise to motor delays? So to summarize the clinical features that makes us doubt the diagnosis of cerebral palsy, I'll just summarize the points. When there is absent the history of any perinatal risk factor for brain injury, or there is family history of sibling with similar neurological symptoms, the motor symptom onset after an initial period of normal development. So there is some kind of spasticity developed after the child had developed very well for a period of time. When there is developmental regression, the child was developing well, and suddenly at 6 months, 8 months, 12 months after seizures or something, the child suddenly regresses. Then we should suspect, could it not be a cerebral palsy? When there are paroxysmal motor symptoms or marked fluctuation of motor symptoms, so that when there is diurnal variation of the motor symptoms, especially in cases of Segawa disease, the dopamine responsive dystonias, the patient have diurnal variation. When there is clinical exacerbation in the setting of catabolic state like the febrile illness, especially in case of mitochondrial disorders, because mitochondria is the energy or powerhouse of our brain. So during times of fever, when the patients with mitochondrial disorders, they suddenly regress dramatically, and they take time to recover, maybe days, weeks. That is not normal. Then we should suspect, could it not be a cerebral palsy? When there is just an isolated generalized hypotonia, so hypotonic variants are not that common. Prominent ataxia, when the ataxia part is very prominent, there are signs of peripheral neuromuscular disease, like in case of hereditary motor sensor neuropathy. The child, there is motor delay and the reflexes are usually absent, and we do the nerve conduction as well. There can be motor or sensory delays, and the eye movement abnormalities. When these features are present in a child with motor delay, then it could be a red flag or it not being a cerebral palsy. Then the typical brain imaging findings that we see in patients with cerebral palsy, like the white matter or the basal ganglia injury that I showed in the previous slide as well, or that there could be deep gray matter injury, like in the thalamus, putamen, and the globus pallidus, especially in patients with high level of jaundice, kernicterus, that presents with dyskinetic CP. The cortical malformations, neural migration disorders like the lesencephaly, polymicrogyria, schizencephaly, seen in patients with cerebral palsy. So if these typical MRI findings are not present, then we should suspect, could it be not be a cerebral palsy? However, in 10% of patients, the MRI could be normal in a patient with cerebral palsy. Usually the cortical malformations are usually because of some genetic conditions. So this is just to show a diagram of a 7-month-old infant with developmental delay suspected of cerebral palsy, but they do with no perinatal risk factor. We can see that there is a white matter hyperintensity in the frontal horn of the lateral ventricle and in the periventricular region, as this is not typical of cerebral palsy. So this eventually turned out to be Pillay-Merzbacher's disease, which is a hypomyelinating condition that mimics cerebral palsy. On the case, so similar motor delay, spasticity was there. Did the MRI of the brain? This MRI is not typical of cerebral palsy. We can see here that the cortex is not that well developed. There is a cortical atrophy is there, predominantly in the frontoparietal area. So this is typical of a glutaric aciduria, where there is a perisylvian prominence and there's cortical atrophy. Then The child with history of like a severe birth asphyxia, we suspect it would be birth asphyxia, but the MRI picture is very is very bad. So you can see the white matter is very undeveloped. There are a lot of encephalomyelitic changes. Even the cortex that looks like a mushroom-like, this is called typical mushroom-like cortex, that's not well developed. It could be because of some molybdenum cofactor deficiency. Then this is the T1 image that shows, okay, so the T1 image showing that there is a typical molar tooth sign that is called when there is brainstem malformation. You can see the molar tooth-like appearance in MRI brain in T1 image. So yeah, so this is typical of Joubert syndrome. So these patients usually present with development delay, hypotonia, ataxia, the isacats, and you do the MRI brain, you see the typical molar tooth sign. So this is suggestive of Joubert syndrome. So this is not cerebral palsy. So the MRI findings are there when that makes us doubt the diagnosis of cerebral palsy. So these are some MRI findings like the hypomyelination, the demyelination, the corpus callosum is very thin, or when there is basal ganglia changes, when it is T2 hypointense, when there is T2 hyperintense, there are certain conditions that give rise to these findings, or there is focal atrophy or hypoplasia. So when the MRI findings are not typical of cerebral palsy, so it could be a red herring that it could not be cerebral palsy. So likewise, metabolic investigations can be done. So there are metabolic causes, there are genetic causes. So we can do genetic tests, we can do some metabolic tests, because this needs to be done. Because if we are able to find the diagnosis, then there are certain treatment available that will have good prognosis. So these positive biomarkers, so we can see that can be done in the blood, it can be done in the urine, or it can be done in the cerebral spinal fluid. So depending upon the provisional diagnosis based on the clinical symptoms that we have, these are the various tests that can be done. And nowadays the metabolic tests, they have been replaced by the genetic tests, because usually the metabolic tests are expensive as well, and they take time to come, and the reports, they may not be they may be inconclusive as well. So eventually we may have to go for the genetic or the next generation sequencing tests. So this is just to highlight the metabolic tests that can be done in a patients of a cerebral palsy mimic. The genetic tests, I'll briefly talk about this. So genetic tests can be done. The commonest one that we send for is the whole exome sequence, but the other one is the CGS microarray. So the CGS microarray, the microdeletions are when they are present, microdeletions, duplications, when they are present in the chromosomes, they are not picked up by the next generation sequencing. So when we suspect some chromosome aberrations that is shown in dysmorphism of the patient, the facial dysmorphism is there, the congenital microcephaly is there, or there is a developmental delay with decreased IQ, autistic features, or other associated congenital anomalies. So we may have to send for the CGS microarray. Then if the diagnosis is uncertain, or that then we send for NGS or whole exome sequence when the features are non-specific. So nowadays even the trial samples can be sent. Along with the kit, the parent sample can be sent. That is called trial sample. Or there are, when you have a clinical suspicion of a certain leukodystrophies or spastic paraplesias, then targeted multi-gene panel can also be sent in genetics. So the differentials in a patient with cerebral palsy, predominantly the spasticity variant, then the dyskinetic variant, and then the ataxic variant. So we'll briefly talk about some of the spasticity, the dyskinetic, and the ataxic differentials of cerebral palsy. So there are, in the spastic one, there are hereditary spastic paraplesias, arginine deficiencies, col4A, biotinase, acardicutyrase, and the leukodystrophies. In the dyskinesia, there are dystonias that are dopa responsive. So it's kind of a magical treatment that happens in a patient with dopa responsive dystonia. So any child with dystonia, so that's why we always go for dopamine trial, because there's no harm in giving this medicine, because the reports of the genetic test for these conditions take time to come. And if it is a case of dopa responsive dystonia, that has diurnal variation, that responds very well to dopamine, and the patient that was not able to walk can suddenly walk. So that's why it's always good that we give a trial of dopa in a patient with dystonia. Then there are other conditions like glutaric acidurias, the glucose transporter deficiencies, the NBIAs, creatine deficiencies, lesnian, cerebral folate deficiency. Then with the hyperkinic disorders like the ADCY5 related dyskinesias. So there are a host of causes that can be non-cerebral palsy. Then patients suspect cerebral palsy but has this ataxia variant. These are some of the differentials, like the glucose transporter deficiencies again, the ataxia telangiectasia, then the hypomagnetic disorder like the PMD or the Pelizaeus-Merzbacher disease that I just showed you the MRI of previously, then the Joubert syndrome, mitochondrial cytopathy, the pontocerebellar apoplasia. So there's a host of differentials of cerebral palsy if the child presents with ataxia. So we'll be talk about some common non-CP genetic or metabolic conditions. So the one that has not mentioned in the metabolic and the genetic condition is the spinal dysraphism. So we should always make a habit in a child with cerebral palsy to see the spine, because there can be certain clues that may be missed. There may be some skin changes, there may be some deformities, the spinal dysraphisms that go unnoticed that makes the child not being able to walk. So the symptoms usually they have progressive neurological deterioration over time, especially during the growth spurts if they are untreated. And the common ones are the tethered cord syndrome. The tethered cord, you can see here in the diagram, the spinal cord level ends at normally L1, L2 level, but because of some fatty growth or some scar tissue, this gets pulled down. So as this gets pulled down, the nerves get irritated, and over a period of time, as the spinal cord grows, over a period of time, the child may have symptoms like the bowel bladder symptoms. The child is not able to walk, not able to move the limb. So this can be picked up with simple clinical examination as well. So clinical examination is a must to see for the lumbosacral area, or there can be some skin pigmentations or some lumps in the lumbosacral area that gives you clue that could it be spinal dysraphism giving rise to this motor delay. Then then the genetic condition presenting predominantly with spasticity. So the hereditary spastic paraplesias. So these are neurodegenerative conditions where the lower limbs spasticity and muscle weakness is there. And there is a considerable variation because more than 80 types of genes have been detected that can give rise to hereditary spastic paraplegia. And based on the type of the genes, the severity also varies from mild symptoms to severe symptoms. And these are often misdiagnosed as having spastic diplegia. So that's why when there's absence of penile risk factors or brain injury and normal MRI, that it could be a red flag. The typical MRI brain imaging, though it may be normal, but in some cases, thin corpus callosum can be seen or ear of link sign can be seen. And other features like Parkinsonism, dystonia, ataxia, ptosis, or posterior coronal signs of ophthalmoplegia can be present. So this is you can see it. So this is the T2 image of the brain. This is the frontal. We can see the hyperintensity denoted by the arrow on the from the hyperintensity in the frontal horn of the lateral ventricle, like a typical ear of a lynx sign. So lynx is a wildcat. So the typical kind of hair that comes out from their ears, top of their ears, these are called. This is typical of HSP, called as ears of lynx sign. And there can be thin corpus callosum as well, that is seen in our sagittal T1 MRI image. So there are list of genes that give rise to host of genes that give rise to hereditary spastic paraplegia. So based on them, they can have predominantly upper motor neuron lesion, lower motor neuron lesion, and the severity can vary as well based on the genetic report of the disease. So we'll briefly go through one case study as well. So a 6-year-old. So common kinds of cases that come in our OPDs that present with cerebral palsy. 6-year-old born to non-consanguineous parents who had delayed attainment of milestone and progressive difficulty in walking only for the last 9 months with frequent falls and no seizures. Birth history-wise, it was a term delivery, 2 kg, low birth weight, cried immediately after birth. However, the child developed symptomatic neonatal hypoglycemia at 20 hours of life and stayed in an ICU for 10 days. then the child had the outcome was uneventful. The child was feeding well, but however, the motor milestone was slightly delayed. The toe walking was at 2 years, speech was at 3 years. The child could walk independently, but however, on the activities of daily living, the child was partially dependent on the parents, and the child had low IQ as well. On examination, the child had microcephaly. There was spasticity of the lower limb with brisk TTRs. However, the upper limbs and trunks were normal, and there was no diurnal variation in the spasticity or the dystonia. There was calf hypertrophy as well. That made you suspect could it be muscular dystrophy. However, the Gower sign was negative. So we did the routine blood tests. So routine blood tests came out to be normal. So like the CBCs, renal function, liver function was normal. Serum CPK was sent slightly high, 326, but not that high, like in the range of thousands that is seen typically in case of muscular dystrophies. And the MRI spine was done, that lower limb weakness was there, that's why. But the MRI spine was normal, and the MRI brain was done. That just showed right frontal non-specific hyperintensity on the right frontal lobe. So based on this, the case summary, there was progressive spastic paralysis, but the worsening of the symptoms was there for last 9 months. There was motor delay that was gradually progressed over last 9 months. IQ was low. Child had microcephaly. Calf hypertrophy was there, but there was spasticity. And the MRI spine was normal, and MRI brain showed non-specific changes in the right frontal region. So the differential conditions, again, cerebral palsy, because the child had developmental delay, spastic paraparesis. However, the child was having these gradual progressive symptoms, and the MRI brain was normal. That was the points against cerebral palsy. Would it be muscular dystrophy? Because there was muscle weakness, it was progressive, calf hypertrophy was there. However, the Gower sign was negative. The child had spasticity, and the CPK was not that high. It was slightly high, but not that high in case of like seen in case of muscular dystrophy, usually seen in thousands. And could it be some metabolic cause like hyperargininemia? There is progressive spastic paraparesis. However, there is no aversion to protein or food. In genetic, could it be Segawa disease, the primary dystonias? But the history, because there was history of progressive spastic paralysis, but there was no diurnal variation, or could it be hereditary spastic paralysis? So these were the differentials that were considered. So based on this, we sent metabolic investigations were sent. The blood lactate was slightly high, ammonia was slightly high as well. So not that high like typically seen in case of urea cycle disorders where there's encephalopathy. However, it showed that there was elevation of the amino acid arginine. Normal range is 2 to 54, it was in 245. So could it be some arginine related metabolic disorder where there is elevated level of arginine? So when we go to the biochemistry of urea acid cycle, we can see here that in arginase deficiency there is elevated arginine levels. Typically elevated in case of arginase deficiency. And when we go to the literature, when there is arginase deficiency, you can see marked elevated level of arginine, lactate, and moderately elevated level of blood ammonia as well. And there is delayed development, spasticity as well. However, the child did not have seizures. So based on that, so we did the genetic test was done. So genetic test showed that it was a arginase deficiency condition, which is autosomal recessive condition, and it is pathogenic. So 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 the diagnosis of arginase deficiency was made, because once diagnosis is made, the treatment changes. So low arginine diet, so different supplements are there to treat for the condition. Similarly, another CP mimic with spasticity, the call4A related spastic cerebral palsy. This is a collagen vascular disorder where there may be antenatal or perinatal cerebral vascular insult that presents like a stroke in neonates. The child may be hemiplegic or quadriplegic. We do the MRI of the brain. The hemorrhage was there initially, now they have resolved, and there is encephalomalacia in the left parieto-occipital area, as shown in this T2 image and this FLAIR image. So you can see there are encephalomalatic changes in. So could it be call4A related disorder? So the imaging gives us a clue in cases of non-CP cases. Then the bioretinase deficiencies. So usually these kind of infants, they present with skin manifestation, hair manifestation, and refractory seizures, and spasticity and developmental delay. You can see there is alopecia, and there are some skin changes, and the child had refractory seizures, and the child had development delay as well. So when evaluated the child turned out to be biotin deficiency disorder, and the child responds very well to biotin supplement. The Acadi Gutierrez, again, the child presenting with microcephaly, spasticity, CP-like picture. This is an inherited autoimmune mediated encephalopathy. Here, the symptoms of microcephaly and brain calcification is there, with intellectual disability and spasticity. And the other typical skin finding that is seen is called the chilblains, the painful condition of the skin, because it is a interferonopathy. It is an immunological disorder that occurs in the body that gives rise to central nervous system manifestation. So there is a skin manifestation, there is painful blisters or fingertip swellings. And in this condition, if we do the CT head, we can see the calcifications along the basal ganglia region, in the thalamic calcifications. So when there is calcification in the basal ganglia thalamic regions in a child with developmental delay, spasticity, with these skin findings, we could suspect could it be Aicardi Gutierrez syndrome, and refractory seizures as well. Then the dyskinetic CP mimic. So the previous 2-3 slides were of the spastic variant. Now the dyskinetic kind of cerebral palsy variant. So these are autosomal dominant metabolic disorder of the dopamine synthesis pathway, because the dopamine synthesis pathway has been disrupted. That's why the low level of dopamine was there. That's why the dystonia is there. The patient may have gait disorder due to food dystonia, but there is a diurnal fluctuation and improvement with restless sleep. So when the child works, the child's dystonia worsens, but when the child takes restless sleep, the child improves. Then in this condition, levodopa, usually even at low doses, is the mainstay of therapy with complete resolution of symptoms. So there will be dramatic improvement of patients in this kind of situation. So that's why it's a routine that we go for a trial of dopamine, levodopa in patients with dystonia. Then the glutaric aciduria type 1. Again, the patient, they, this is the autosomal recessive condition due to GCDS deficiency. The patients usually present with encephalopathic crisis, mainly triggered the child with development delay. This has this encephalopathic crisis, usually triggered by illness, usually seen in the first 6 years of life. And with each episode of encephalopathic crisis, there is this striatal injury. And the consequent, that's why when the basal ganglia is involved, then there are these dystonic movements. And when we do the MRI of the brain, we can see that there is, again, this subdural hematoma, there is this cortical atrophy is there, there is perisylvian widening is there. So this is very typical of glutaric aciduria type A. And on examination, the child may have macrocephaly, hypotonia, choriotheater movement, or dystonic movement. And the MRI picture we've just described. Then the another condition with dyskinetic CP-like picture is a cerebral folate deficiency. So nowadays the news have come that in all autistic patients give a trial of folic acid, because we suspect that it could be, if it is because of cerebral folate deficiency, when the child has developmental delay, autistic features, then the leucovorin or the folinic acid helps. The cerebral folate deficiency, it typically presents between 4 to 6 months as infantile form, mainly in the form of the behavior changes or the refractory epilepsy, where after 1 year of age, it presents with spastic and ataxic syndrome, and then the child gradually progresses to dystonia. They have developmental delay. They have spastic ataxic kind of movements eventually that give rise and then that progress to dystonia, and they have autistic features as well. And in this condition, what we do is we send the CSF for the levels of M tetrahydrofolate. We have to go to the pathway. So the level of the MTHF usually is low in CSF, whereas there is normal folate levels, plasma folate levels. And if we go for the NGS, it can detect FOL around gene may be positive. And then another is the Lesch-Nyhan syndrome, which is a X-linked recessive disorder of purine metabolism, where there is motor disability, but the child has self-injurious behavior and cognitive impairment. The symptoms, they usually start at the age of 3 to 6 months, and subsequently between 6 to 24 months, they have the generalized dystonia is there. So initially they are diagnosed as dyskinetic CP, and the blood investigation, the simple blood investigation that we do in such cases is the serum uric acid level. The uric acid level is involved in the purine metabolism pathway. So the levels of uric acid is high. So when we do the blood test, when we send the uric acid, if levels are high, we suspect could it be early manifestation of Lesch-Nyhan syndrome. The another CP-like manifestation in a patient who has dyskinesia is ADCY5 related dyskinesia. So this is a genetic condition where there is early onset non-progressive hyperkinetic movement disorder. I'm not sure whether this will play. Yeah. So we can see here. So the child has this dyskinetic movements. Yeah. Sorry. Okay. So here this hyperkinetic movement disorder when you suspect in a child with cerebral palsy, could it be a genetic condition? Okay, so these patients can present with dystonia, chorea. We could see the chorea attitude movement. They are typical episodic and sleep related. And the dyskinesia, they may exacerbate upon awakening or falling asleep or during intercurrent illness for a few minutes or up to days. So we did the genetic test and it turned out to be ADCY5 mutation. Then another ataxic variant of cerebral palsy is called as ataxia telangiectasia, which is a multisystem autosomal recessive condition, which is caused by mutation in the ATM gene, where there is progressive ataxia. Initially comes the ataxia during the early years, then the eye manifestation with the telangiectasia can be seen. That can be typically seen in the ocular area, can be seen in the side of the lips, the ears, around the joints. And we do the MRI brain sagittal section, we can see the cerebellar atrophy. Then another ataxic variant, the Pelizaeus-Merzbacher disease, which is a hypomyelitic disorder, congenital disorder. The child presents during infancy with head bobbing, nystagmus, psychomotor retardation, tremor, ataxia, and dystonia and athetosis. They may occur, and then there will be progressive spasticity. So here we can see again, this was this MRI picture sent in previous slide as well. We can see here the subcortical deep white matter in the frontal area is hyper intense, is intense, and even in the periventricular areas it's intense. And to say it is a hypomyelination, we have to see a series of MRIs. So if done over a period of 6 months, if the myelination is not appropriate, then we can say for sure that it is a hypomyelitic disorder. So it could be an early manifestation that this is not a typical CP child. Then the Joubert, the autosomal recessive, which is characterized by hypoplasia of the cerebellar vermis. The pathognomic finding that we see here is the Maillard tooth sign. These patients usually have developmental delay, the typical head mobbing, the the nystagmoid eye movement. So this could be a genetic condition, the Joubert syndrome. Then the mitochondrial disorders, that can be a cerebral palsy mimic as well, which is a multi-system organ disorder. They often have neurological dysfunction, but usually they are rapidly progressive. So cerebral palsy, it is a non-progressive disorder, but these conditions are progressive. They can have early isolated ataxia, multi-system involvement, dystonia, or hypotonia with slow course that can be observed and confused as cerebral palsy. So here, this is a condition with the SCA2 gene mutation where you can see widespread white matter injury, and even you can see some areas of cavitation as well that is shown by the arrow. So the take-home message, that all motor delays are not cerebral palsy. The cases which history are not typical of cerebral palsy, like typical birth history of hypoxia, brain injury is not there, the typical MRI finding is not there, then these cases need to be investigated. the most prominent type of motor symptoms should be identified. So, as discussed previously, there are three main motor symptoms: the spastic, the dyskinetic, and the ataxic variant. So, based on this, the differentials should be considered. The MRI, in some conditions, genetic metabolic conditions, gives us a clue, but in some conditions, the MRI may be normal. So that's why we judiciously investigate for cases for metabolic and genetic etiology based on our clinical findings. Thank you.
Thank you, Dr. Asim, for your nice presentation. It was great hearing you from you. I know we have got this chance to hear from Dr. Asim, who is a renowned pediatric neurologist in the country. So, anyone of you have any questions? You can ask. If you don't have any questions, then we'll just end up the session and we'll. Do you have any questions? Anyone of you? You can raise your hands or you can just turn on your mic and can ask the questions.
So so the main point from my side is that
Yeah.
just try let's us try to classify the cerebral palsy in three based on three motor symptoms,
Mm,
like the spastic type. Is it spastic type? Is it dyskinetic type? Or is it a
mm,
ataxic type? The spastic type is quite common. If there is dyskinetic and if there is ataxic variant and there is suspicion, slight suspicion, could it really be cerebral palsy? And there's progression of the symptoms as well. Then it could be a red flag that it could not be a typical cerebral palsy, because once we give a diagnosis, it makes a world of difference to the parents, and they can, and for the another pregnancy as well. If the parents ask, will next pregnant when I'm pregnant next time, my next child, will he have similar feature to him or not? So giving us a diagnosis, even though the treatment may not be there possible for all cases, but this will make a huge difference to prognosticate and to counsel the parents as well. It is very beneficial once we come to a conclusion that no.
So when a patient come to a, like if we are talking about undergrad who is seeing a patient, uh, if someone is coming to their clinic when they are suspecting there is something going on with cerebral palsy, what things they need to look upon?
So first is always are we dealing with the cerebral palsy? Because based on the history, so antenatal risk factors are there, and on examination there is spasticity is there, the upper motor sign is there, that is typical. Yeah. But when these findings do not go hand in hand, and risk factor is not there, but the child is having development delay, then that should be a earliest clue. Could it not be a typical cerebral palsy case that we are dealing with? Especially then we go for commonest investigation is the imaging that we have in our part of the country. So imaging ma pani, the CT will not be that helpful, right? So that's why MRI brain will give a much more information, right? Given because CT scan will cost you 6 to 7 thousand, MRI will cost you 11 to 12 thousand. So roughly यति CT भन्दा पनि MRI is far better to visualize the overall anatomy of the gray matter and white matter of the brain. The kind of malformation can be missed. है कति केसहरू हुन्छ पहिला CT scan is normal, but we do the MRI is abnormal. So just to sensitize that MRI is far better in cases of cerebral palsy cases.
Okay, then, as we don't have any more questions, then we'll thank Dr. Asim for his valuable time. And thank you again for your nice presentation. Have a nice day, everyone.
Thank you, Dr. Pesla. Bye.
Okay, bye bye.
Bye, everyone.